Good afternoon, Dr. Ale.
Hi, hello.
Thank you. I would like to ask you about Mrs. Lama. She's next door to me.
Is she the lady who was going to ask about stopping tamoxifen? Because I think Sister Alhan told me about her yesterday.
Yeah, great memory. Yes, she is.
Yeah, fine. So let me. These are her notes. Let me just have a quick look at her notes and see what's been happening here.
I would like to inform you one information about her. She has been on tamoxifen for almost 2 years now, and she would like to be pregnant.
I see. Yeah, that's fine. Yeah, good, fine. So let's see here. So right. So she underwent mastectomy and sentinel lymph node biopsy 2 years ago, and she was found to have invasive ductal carcinoma, measuring 1 centimeter in size, 0 out of 2 lymph nodes. She's strongly ER and PR positive and Her2 negative.
Yes.
An oncotype DX is sent and came back with a score of 9, so no chemotherapy was offered.
Yes, I know you're gonna ask me this question, and I definitely know the answer.
Pregnancy in a woman previously diagnosed with ER-positive breast cancer may be detrimental by means of endocrine stimulation. However, a case-controlled study on patients with pregnancy after breast cancer revealed no survival differences between ER-negative and ER-positive patients. Predicted from the patient's age, risk of recurrence, adjuvant therapy, and ovarian reserve, many oncologists will offer 2 years of anti-estrogen therapy prior to taking a patient off the treatment so she can pursue pregnancy. Remember, tamoxifen is a teratogenic drug and it should not be given to patients who are pregnant. Dr. Ali, can I ask about the patient, please?
Yeah, sure. Go ahead.
Yes, I've got the patient's notes here with me to read from, if you don't mind.
You don't know the patient history?
I'm sorry, I was on call last night, so I didn't have time to prepare, but I've got the notes here, so
all right,
to apologize. So this is Mrs. Hala. She is a 63 years old lady who had left a mammogram to investigate a breast lump and revealed an 8 millimeter breast mass with no lymphadenopathy. So the stage is 1A breast cancer. The biopsy of the mass revealed an ER/PR positive, Her2 negative, invasive ductal carcinoma. The Nottingham score is 5 and the Chi-67 is 5%. She's well and fit, and her blood results all within normal range. So the plan is to do a lumpectomy and sentinel lymph node biopsy next week. But I'm not sure if we need to do any other tests before we go ahead for surgery.
Well, you need to tell me that.
In general, systemic imaging for patients with clinical stage 1, 2, and 3 breast cancers should be performed based on the clinical picture and whether a patient has concerning signs or symptoms of malignancy. If labs are found to have abnormal values, for example, elevation of alkaline phosphatase or abnormality in liver functions, then imaging could be ordered to rule out metastasis as well. But also keep in mind that in early stage breast cancers, sometimes bone scans and CT imaging can pick up false positive findings.
So we performed a right side mastectomy and sentinel lymph node biopsy on Mrs. Nawal, and we're here today to review the pathology.
Right, sure. So as you know, the initial biopsy revealed a breast invasive ductal carcinoma that was ER/PR negative. Her2 was equivocal +2. The tumor was high grade. So now we have received the surgical specimen and repeated the Her2 status. The immunohistochemistry of Her2 remains +2. A dual probe ISHSA was done and revealed an HER2 CEP17 ratio of more than or equal to, and the average HER2 copy number is more than or equal 4 signals per cell. I have also to say that I've asked Dr. Maher, who is the other pathologist, for a second opinion, and he concurred with my findings.
Right, I think we have to check with our oncologist. What do you think?
This patient has a high-grade tumor that is ER negative and PR negative, and adjuvant chemotherapy would be offered. However, the question is whether she is HER2 positive or not. In 2018, updated guidelines regarding HER2 testing in breast cancers were made by the American Society of Clinical Oncology and the College of American Pathologists, which were endorsed by the NCCN. HER2 is defined as positive by IHC +3 when more than 10% of the cells harbor complete membrane staining of the antibody. It is also positive by ISH if the number of HER2 gene copies is more or equal to 6, or the HER2 CEP17 ratio is more or equal to 2, and the HER2 copies are more or equal to 4, or HER2 CEP ratio is less than 2, and the HER2 copies are more or equal than 6.
Dr. Ahmed, sorry to bother you, but can I discuss with you the case of Mrs. Fatima, a patient I'm seeing right now?
Yes, of course. Isn't she the patient whom we discussed a couple of weeks ago with the relapsed cancer?
Yes, correct.
Okay.
So
sure.
This patient briefly, she's well right now, and she was diagnosed with a triple-negative breast cancer in which she had a mastectomy 2.5 years ago. Her tumor was 2 centimeters and 0 out of 3 lymph nodes on sentinel biopsy. Pathology at that time showed that the proliferation index Ki67 is 97%, grade 3 tumor, and genetic testing was done at the time and it showed no mutation. She completed the standard adjuvant treatment with AC Taxol chemotherapy, and she underwent surveillance. Recently, she developed a mild dyspnea, and a CT scan have revealed over 10 pulmonary masses with no disease elsewhere.
Yeah, but I thought the MDT suggested to do a PET scan. Did you have it?
Yes, indeed. She did already the PET CT, and it confirmed the presence of FDG-avid lung lesions with no other lesions in the body.
Right. So what would you do next? Receptor status, ER, PR, and HER2 can evolve when going from the localized to the metastatic setting. Data shows that these 3 receptors can be unstable throughout tumor progression. Changes in the ER has been shown to occur in up to 40% of the cases, while changes in the HER2 has been seen in up to 30%. This patient is likely to have a metastatic breast cancer that is triple negative. However, there is also a chance that her tumor has now become ER positive or HER2 positive. If so, she will have an additional menu of therapeutic options available to her. Given that she has no signs of visual crisis and is clinically stable, there would be time to order a biopsy and confirm pathology receptor status. If this patient has been confirmed to have a triple negative disease, then it will be important to check for actionable genetic mutations that might provide more therapeutic options.
This is Acting for Clinical Education. Like, share, subscribe.
Don't forget to check the resources down below and join us every Thursday 8 p.m. for more videos.